Respiratory complications of rheumatoid arthritis. Etiology. The association of rheumatoid arthritis with lung disease may be due to rheumatoid-associated lung disease, drug-related lung disease secondary to drugs used to treat rheumatoid arthritis, infection secondary to immunosuppression, coexistent medical conditions. Epidemiology. Although rheumatoid arthritis is more common in women, rheumatoid lung disease occurs more frequently in men who have long-standing rheumatoid disease, a positive rheumatoid factor and subcutaneous nodules. Pulmonary involvement is one of the most frequent extra-articular manifestations of rheumatoid arthritis. The most common lung diseases associated with rheumatoid arthritis are interstitial lung disease, ILD, and pleural effusion. Approximately 30 to 40% of patients with rheumatoid arthritis demonstrate either radiological or pulmonary function abnormalities indicative of interstitial fibrosis or restrictive lung disease. Although rheumatoid arthritis disease activity is important, smoking is the most consistent independent predictor of radiological and physiological abnormalities suggestive of ILD in rheumatoid arthritis. Clinical presentation. The range of pulmonary problems is wide. Rheumatoid nodules. Rheumatoid nodules are the only pulmonary manifestation specific to rheumatoid arthritis. They are typically benign but can lead to pleural effusion, pneumothorax, hemoptysis, secondary infection, and bronchopulmonary fistula. Kaplan's syndrome. This is the combination of rheumatoid arthritis with pneumoconiosis related to mining dust. Look for rapid development of multiple basal peripheral nodules in the rheumatoid arthritis patient who has a history of exposure to mining dusts. This can progress to progressive massive pulmonary fibrosis. Interstitial lung disease. Radiographic findings of ILD occur in 2 to 5% of patients, while diffusion capacity abnormalities occur in 40%. High-resolution CT scans and histology have shown even higher rates, but clinically significant disease probably occurs in 5 to 10% of rheumatoid patients. Bronchiolitis. Bronchiolitis obliterans with organizing pneumonia, bilateral parenchymal opacities, often with preserved lung volumes. Typically presents as a relapsing, non-resolving pneumonia that does not respond to antibiotics. Steroids can be curative. Obliterative bronchiolitis, rare, usually fatal condition. Associated with penicillamine, gold, and sulfasalazine treatment. Presence with rapid onset dyspnea and dry cough. Fever is uncommon. Bronchiectasis. About 10% of patients may show radiographic signs of bronchiectasis and it may occur in the absence of ILD. Rheumatoid arthritis patients with this complication are more likely to be heterozygous for the transmembrane conductance regulator mutation seen in cystic fibrosis. Arteritis. Arteritis of the pulmonary artery and lung is rare. Signs of systemic vasculitis are usually present. Infection. Respiratory infections account for 15 to 20% of deaths in rheumatoid patients. Pleural effusions. These are common in rheumatoid arthritis, are exudative and have a low glucose. Occasionally an empyema may develop. Lung cancer. Lung cancer is more common in patients with rheumatoid arthritis than in normal control subjects. Other diseases. Patients with rheumatoid arthritis can develop apical fibrobullous disease, apical fibrotic cavity lesions similar to ankylosing spondylitis, thoracic cage immobility causing restrictive lung disease and, rarely, primary pulmonary hypertension. Secondary pulmonary hypertension, due to ILD, is more common. Methotrexate pneumonia. Methotrexate pneumonia is an unpredictable and life-threatening side effect that may occur in 1 to 5% of patients given this drug. Presentation is often subacute, with symptoms of cough, dyspnea, and fever often present for several weeks or months before diagnosis. Progression to respiratory failure can be rapid. Early diagnosis, cessation of methotrexate and treatment with corticosteroids and/or cyclophosphamide are important in management. There is a high rate of recurrence of lung injury after a rechallenge with methotrexate. Penicillamine and gold can also cause pulmonary complications.